Last time I had discussed with you types of rejections and how the rejection reactions takes place and within what duration the rejections will take place based on the triggered immune response in the host. Host is nothing but the recipient after the organ donation. Now we'll see today exactly the mechanism of rejection, that is effector mechanism of rejection. So before that, the before immune system gets stimulated in the host for the graft, the host will have in the first step of graft, it will be a stimulation stage or sensitization stage when the graft is given to the recipient and the graft is done and blood vessel contact has been established with the graft, and now the immune system of the host or the recipient will start sampling the antigens that are present in the graft, and that is the first step. And that first step of sampling of the fresh graft into the host is called as sensitization phase. Okay, and after the sensitization phase, the immune response starts, and that immune response that begins involve both cell mediated and humoral immune response, that is called as effector mechanism. In two different manners, the immune response responds to the graft. First, I will take the mechanism that is involving through passenger APCs. Now, what is meant by passenger APCs? The passenger APCs belong to the donor, that is, the person who is donating the organ. Let us presume that the recipient has gone through liver transplant. If the recipient has gone through liver transplant from the donor, that liver might have been washed of all blood and other things by passing the saline, human saline through it. But you cannot get rid of the immune cells which are already there in that graft when that organ was functioning in the donor. In the donor, the organ would have had some immune cells in it, and that too the macrophages. Each tissue has its own macrophages. Now let us presume that the tissue which has been grafted has macrophages as well as dendritic cells, which are the donor's APCs, antigen presenting cells. Now, what would these donors APC contain? They will have on their class 2 MHC the antigens specific to that organ, that is, which is donated, and those antigens of the donor will be presented on class 2 MHC. And these passenger APCs, that is macrophage and dendritic cells, which are there in the donor, when they present these antigens of the donor origin, the recipient's TH cells which come in contact with these antigens cannot keep quiet. Now that the blood supply has been established, the recipient blood samples the donor's organ. It will come through the organ, passes through the organ. As it is passing through the organ, now recipient's immune cells are also flooding the grafted tissue. In the blood, there are T cells. In the blood, there are B cells. In the blood of the person recipient, there are the immune cells like NK cells, CD8 cells, and even NK cells, which are coming in contact with now the antigen in the donor's organ. As soon as the passenger APC of the donor origin presents the donor's antigen on class 2 MHC, whichever the TH cell that comes in contact with that antigen first time, immediately it will undergo activation. It has been presented with now a foreign antigen, and it was not tolerized against this antigen because it had not seen this antigen before. It will get activated. As soon as TH cell gets activated, it will now differentiate into TH1 cell and TH2 cell. The TH2 cells, which are formed as the clones of that sampled antigen, will start secreting cytokines like IL-2, IL-4, IL-5, IL-6, which are responsible for the activation of B lymphocytes, which are there in the recipient. At the same time, the TH cell, which has differentiated itself into TH1, that will differentiate to form TDH response. That is the delayed type hypersensitivity response. And delayed type hypersensitivity response by the TH1 cells involves the production of inflammatory cytokines like interferon gamma, and the tumor necrosis factor beta. So tumor necrosis factor beta and interferon gamma will be responsible for inflammatory reaction. And now there are other cells which are dependent on IL-2. Okay, and those other cells will be the cytotoxic T cells. The cytotoxic T cells will be proliferating because the recipient cytotoxic T cells have come in contact with the donor's antigen, which is already there on class 1 MHC presented by the donor's organ. Please remember, donor's organ has nucleated cells, and the donor's organ tissue specific antigens of that particular tissue, and had clearly mentioned that the class 1 MHC is expressed by all nucleated cells of all organs, and those antigens that are expressed on class 1 MHC will be always the organ specific antigens, and they become the tissue markers. And only by accident the class 1 MHC will present the viral or bacterial antigen, provided that organ is infected by a virus or bacteria. Now let us not consider that. Let us consider only now the organ specific antigens. So the organ specific antigens of the donor's organ will be expressed on class 1 MHC, and those that are expressed on class 1 MHC are immediately recognized by the CD8 T cells of the recipient. And as soon as they recognize that antigen, they lock themselves with that particular antigen on class 1 MHC. Now they are going to be activated. And you know what happens with the CD8 T cell activation. They are cytotoxic cells. They will start activation and start producing the perforins and granzymes, and they will start now pouring those granzymes and perforins onto the organ and start damaging the organ. At the same time, the CD4 T cells which were activated are undergoing clonal proliferation, and some of them have already become memory cells. They become the memory cells. And those TH2 T cells will be producing excess amount of those cytokines which are activating the B lymphocyte, and the B lymphocytes will now start producing the antibodies against those antigens that have been sampled from the donor's tissue. Different types of antibodies will be produced against different types of antigens of the donor tissue. And those antibodies will come into circulation within 14 days. Within 14 days. But within 7 days, the antibody production starts. And the high titer antibody will be there in the blood circulation of the recipient by 14th day. And those antibodies now will be acting on the organ directly because they are the antibodies produced against the antigens of the organ, which were sampled and they were presented by the passenger APC. And once the antibodies come and bind there, you know the fate. As soon as antigen antibody complex is formed, complement mediated lysis will start. Remember, in the diagram, it is just shown that antibodies are coming and binding to the organ on the surface, but it is not true. The antibodies will be inside. Why? Because blood is passing through the organ. And IgG molecule can pass through the blood vessels. It can diffuse out of the blood vessels. And it is reaching every nooks and corners of the organ that is grafted and binding to those antigens through specificity. And as soon as antigen antibody complex is formed, the host will mount complement mediated lysis. Already the damage has been initiated with the CD8 T cells, cytotoxic response. Now the antibodies are doing the damage, that is complement mediated lysis. At the same time, the recipient's other immune cells like NK cells, eosinophils, neutrophils, and macrophages, which are sampling of the graft, will not keep quiet. They are all activated now. Once they are activated, there is tremendous amount of cytokine that is being produced by the activated TH cell, which will help these cells to be active. And they will express the FC receptor on their surface, and to which the circulating antibody that is produced against the donor's organ will bind to the FC receptor. And those cells like NK cells, macrophages, eosinophils and neutrophils will mount now ADCC response, antibody dependent cell mediated cytotoxicity, that will result in secretion of large amount of lytic enzymes, perforins, granzymes by these activated cells, that also result in damaging the donor's organ. Same time, the DTH response that has begun, that is delayed type hypersensitivity through Th1 T cells, will be secreting those cytokines of inflammatory nature, and those inflammatory cytokines will be keeping the macrophages active of the recipient, and those macrophages will be secreting the lytic enzymes and bring about damage to the grafted organ. So this immune response has begun by sampling the antigen on passenger APC. Passenger APC. Passenger APC is the APC that was belonging to the donor, which was there in the organ, which had the organ specific antigens on its class 2 MHC, which has triggered this immune response. That is one arm of the immune response. The second arm of the immune response is the host antigen presenting cells, that is recipient antigen presenting cells, which are there in plenty, will be sampling the antigens of the donor's organ, and they will be also simultaneously undergoing activation and start activating another batch of TH cells, and they will also mount an immune response. Now it is like double-edged knife. First, immune response may begin through passenger APCs. The other immune response simultaneously will begin through the recipient's APCs. The recipient's APCs, which had not come across these antigens, will recognize these antigens of the donor organ and undergo instantaneous activation and start presenting the antigens to the Th cells. And the immune response that builds up both will be cell mediated, involving all sorts of immune cells which will mount an immune response against the organ. Humoral, where the Th cells will trigger the B lymphocytes to produce the antibodies against the donor antigens. And the process is same. The process will be same. And the double immune response mounted against the organ will not allow the organ to survive. It will be completely destroyed. Lytic enzymes will act in such a way that the organ will be dissolved at the place where it is grafted. Now, it is always necessary to condition the patient who is receiving the graft to not to mount such a violent immune response against the graft. Otherwise, the graft will be a failure. Entire procedure of surgery and grafting will be a failure. Lot of money will be lost. To prevent that, the person should be administered the immunosuppressive drugs beforehand, before the graft is grafted onto the person. And his immune system is kept at a very, very low minimum threshold level to safeguard his immune system from other infections, but will not be able to mount a violent immune response against the graft, so that the graft will survive. So those immunosuppressive drugs which are administered to the patient are not friendly. Please remember that. They do cause side effects, and they're also called as chemotherapeutic drugs. They're also used in cancer chemotherapy. In addition to other cancer chemotherapy drugs, these are also used. So we'll talk about those drugs little later. But for the time being, I hope you understood the mechanism. But that effector mechanism has to be suppressed. To some extent, it is suppressed by the immunosuppressive drugs. The mechanism, all that I will deal with that little later. There is one more type of graft reaction that I will talk now. That is with regards to now, all this effector mechanism I discussed is with respect to the organs like liver, kidney, heart, okay, or maybe pancreas, okay, or intestinal piece, okay, like that, the organs of different functions, but they are not immune organs. All right, they're all organs of different functions. When they are transplanted, this type of effector mechanism takes place. Now let us take, when you transplant an organ involved in immune response, that is primary organ of the immune response, that is bone marrow. When you transplant a bone marrow to a person, okay, what happens and what type of reaction is built up in the person, okay, and that reaction that builds up against the bone marrow transplant is called as graft versus host disease, or it is called as GVHD syndrome. GVHD syndrome. And you know that there are people who receive bone marrow transplantation, and such people are either suffering from certain types of blood related cancers, that is leukemias, or they may be having some blood related disorders. They may be having sickle cell anemia or thalassemia or different kinds of hematopoietic abnormalities. And such people will receive the bone marrow, and the donor bone marrow is transplanted into them. And here we are talking primary lymphoid organ responsible for the immune response of a person is going to be transplanted. In that case, the recipient, the person who is receiving the bone marrow, okay, should have destroyed his own bone marrow completely. And that is done through radiation and chemotherapeutic drugs. For a week's time, before the bone marrow transplantation is done, the recipient is subjected to radiation on daily basis to the major regions of the body where the bone marrow is responsible for the production of immune cells. That is the humoral region of your arm as well as the femur region of your thigh. These two regions have highest amount of bone marrow and they are responsible for production of immune cells. And it is highly irradiated. It is subjected to radiation. After radiation, simultaneously the person is given chemotherapeutic drugs, and those chemotherapeutic drugs will destroy the bone marrow. And now that person who receives who is supposed to receive the bone marrow transplantation is totally immunocompromised. Totally immunocompromised means he cannot produce any immune cells of his own. Is completely immunocompromised. After immunocompromisation, that person should be kept in such a careful condition that he should not come in contact with any infectious agent. At that time, he should be completely kept in aseptic condition. And then the bone marrow transplantation is done. When the bone marrow transplantation is done, now donor's bone marrow, which has been matched with this MHC, it has been matched. And I already told you that there is no possibility of getting 100% match. And that bone marrow might have been donated by his own sister or brother or from parents or his very close relative, where the MHC is matching somewhere about 75 to 85%. And after the transplantation of that bone marrow into that person, now is already under chemotherapeutic treatment. That chemotherapeutic dose is decreased. Now that bone marrow which is transplanted is allowed to express itself. Okay, it is now an immune system that is given to him, and that bone marrow will now start producing the immune cells. It will take about a week for that bone marrow to start producing active cells of the immune, and the person is now kept under close observation. Minimum dose of chemotherapeutic drugs are administered to prevent the bone marrow rejection. And that bone marrow which is donated to him now will have all the immune cells of the donor. The recipient's all immune cells now destroyed. They are no more there. There are no macrophages, there are no dendritic cells, there are no stem cells. Okay, there are no B lymphocytes, there are no TH cells. He doesn't have his own, or the recipient does not have his own immune cells. Now, whatever he is going to depend on is the donor's immune cells that are going to be produced from the bone marrow. Remember, those donors' bone marrow immune cells were not exposed to the antigen of the recipient earlier. They will now sample the antigens. As soon as the blood supply of the recipient is established with the bone marrow starts producing all immune cells and they will start coming into the circulation. Macrophages of the donor, dendritic cells of the donor, TH cells of the donor, TC cells of the donor, NK cells of the donor, B lymphocytes of the donor, all will start coming into circulation. Now the recipient is having the borrowed immune response, and those cells of the donor origin are sampling the recipient's antigen. So the donor's immune cells get activated. The donor's immune cells will get activated because they were not exposed to the recipient's antigen. They are now sampling those antigens because they are traveling through his body. They are going through the different organs. They are circulating and they are coming across different types of antigens of the host origin. They are activated. And that is why it is called as graft versus host disease. Graft is now mounting an immune response against the host. In the former case, what we had talked about in the effector response, the host is mounting an immune response against the graft here, which is quite natural. But here, in the case of bone marrow transplantation, it is opposite because the recipient is immunocompromised. The bone marrow, that is the primary immune organ, is now responsible for production of all immune cells, will sample the antigens of the recipient and start getting activated. And the TH cells, moment they get activated, because the macrophages of the donor bone marrow will sample the antigens, as well as dendritic cells will sample the antigens of the host, will start presenting them to the TH cells on class 2 MHC. And as soon as TH cells of the donor are activated, they are going to start secreting the cytokines. They will be delineated into Th1 and Th2 cells, and they will mount an immune response. At the same time, when they are secreting the cytokines, the other cells of the bone marrow origin, like CD8 T cells, as well as NK cells, will not keep quiet. They will also get activated against the recipient's antigen. And they will mount the graft versus host mounting of immune response. That immune response which is mounted by the donor bone marrow, graft versus host disease, will in causing, in fact, destruction of the organs of the host. The bone marrow, which is mounting an immune response now, will now start immune response, a systemic immune response. Systemic means all over the body. Body will start developing rash, skin rashes, red patches on the skin, which is erythema. Blood vessel rupture will start on the skin surface. Weight loss will be there in the person. Growth will be inhibited. Cells will be inhibited from proliferation because they are being attacked by the immune cells. There will be splenomegaly. If the person's left side below the stomach in the abdominal region, if you palpitate, you will see the recipient spleen will have gone into a larger size. That is called a splenomegaly. Fever will be there. The RBCs are going to going to be destroyed. Why? Because those RBCs of the host, okay, which were there as residual RBC, they were not cleared. You cannot drain off all the blood of the host when you are transplanting bone marrow. You have compromised the bone marrow, but there was blood circulation in the host, and those RBCs are going to be now attacked by the immune cells. There will be hemolysis, and person may experience diarrhea. And that is graft versus host disease syndrome. And that can be mitigated, means you can suppress that. You know, this type of reaction will take place and the host will suffer a lot of damage. The doctor will prepare the host who is immunocompromised, okay, by giving him bare minimum doses of immunosuppressive drugs. And most commonly used immunosuppressive drugs for prevention of graft versus host disease are cyclosporin A and methotrexate. These two are the mildest among the chemotherapeutic drugs. Cyclosporin A and methotrexate. Action of both, I will be talking about that in the immunosuppressive drugs. And they will have minimum effect, but at the same time, they can suppress the immune response of the bone marrow and keep the immune response at a very, very low key. And remember, complete depletion of T cells is not advisable in the bone marrow. The bone marrow before transplantation, it is going to be treated with monoclonal antibodies against the T cells. Okay, and T cells which are active in the bone marrow of the donor will be now suppressed because they have been bound by the monoclonal antibodies. And those monoclonal antibodies are directed against the T cell receptor and CD4 receptor of those T cells, or even CD3. Any of the three receptors are being blocked by the monoclonal antibodies. But complete blockage is not advisable. Complete blockage of the T cells on the bone marrow will make the bone marrow completely immunosuppressive, and it will be of no use transplanting such a bone marrow. So minimum number of T cells will be kept active in the bone marrow, and maximum number of T cells are being suppressed by the monoclonal antibody treatment. And the host is going through immunosuppressive drug treatment, that is cyclosporin A and methotrexate. And low T cell activity in the bone marrow, okay, will keep the GVH reaction, that is graft versus host reaction, at a minimum level. It won't be violent. Whatever the reaction that explained earlier, I explained to you earlier, if you don't take these precautions, that is the reaction going to take place, and the transplantation of the bone marrow will damage the individual, and the individual will be gone. To prevent that, precautions are taken, immunosuppressive drugs are administered, and T cells are minimized in the bone marrow by treatment with monoclonal antibodies. And then low level of T cells will keep the bone marrow active and support the immune system of the patient. And now he will be dependent on the donor bone marrow for his immune response. But it should be of a very low immune response. Remember that. And all throughout his life, after the receival of the bone marrow, the person will be kept on immunosuppressive drug at a minimum dose to prevent graft versus host disease. Moment you withdraw the immunosuppressive drugs, the graft is going to mount an immune response against the person. So therefore, the person is under continuous observation by the doctor, and periodically he has to visit and get himself checked for the immune response that is being mounted by the bone marrow. At the same time, those leukemic patients who receive the bone marrow graft, by having low GVH in them, that is graft versus host disease, they can suppress the leukemic cell. It has been observed that the progression of leukemia is going to be suppressed in them. Because one thing, even if you say that the person was completely immunocompromised by radiation, by destroying the bone marrow, by giving the chemotherapeutic drug, but can you assure that the person who was immunocompromised has lost all the immune cells of his bone marrow? Can you assure that there is small residual bone marrow is not there in him, which is alive, which did not go through the radiation or which did not experience chemotherapeutic drug toxicity? So that will be responsible. If the person is leukemic, the leukemia originates from the bone marrow. It is hematopoietic disorder. And there is a possibility those cancers will be lurking somewhere and they may emerge. And if those cancer cells, leukemic cancer cells emerge, they will be destroyed by the donor's bone marrow cells because of low GVH. And that is the only advantage that is experienced in the bone marrow transplantation in the leukemic patients. So this is how the violent graft versus host disease is prevented by keeping the person under immunosuppressive condition by administering the immunosuppressive drugs of minimum toxicity. That is cyclosporin A, which is the wonder drug of transplantation, and then methotrexate. The mechanism of these two, I will deal with that little later. So I just want to tell you about the experiments that were conducted using mouse. This is the normal mouse, okay, which has normal the body architecture with a lot of hair on the skin, looking nice, fluffy, everything. And when you take a mouse called as nude mice or nude mouse, it looks like this. For majority of cancer experiments, majority of transplantation experiments, this mouse is being used. Even for the experiments on autoimmune response, this mouse is used. This mouse is genetically a thymic mouse. It has a genetic anomaly, okay? And that genetic anomaly is that it doesn't produce the thymus. There is no thymus in this mouse since its birth. And it has been maintained on a aseptic condition. Imagine this mouse doesn't have thymus, means it doesn't have cell mediated immune response, means Th cells are not there, CD8 T cells are not there. Of course, NK cells are also derived from the T cell lineage, they are also not there. Means it is very, very vulnerable for infections by virus and bacteria. It has a short half-life, means the mouse lives for a very short duration, and it has to be kept under such an aseptic condition that there are no other mouse of this variety are reared with it. It will be reared separately as though in an ICU. You know how aseptic is the ICU, intensive care unit in an hospital, where a person goes through a surgery to prevent bacterial and viral infection. Such type of atmosphere is required for maintaining this mouse, and this mouse is very, very expensive. And it was not produced by somebody, it happened genetically in one laboratory when the mouse were being bred and continuously being used. Suddenly some genetic mutation took place in the mouse and the thymus development stopped. There was no thymus, and the mouse, whichever that was produced from that mutation, was nude mice or nude mouse. It doesn't have hair on the body. Okay, it is completely blank and very, very sensitive, and has only humoral immune response, that is B lymphocytes, but no immune memory, because there are no Th cells in it. Since Th cells are not there, there is no Th cell dependent B cell response. Only the antibodies that are going to be produced by this mouse will be against the foreign antigens that you inject. Since it has been protected from the atmosphere from bacterial and viral infection, it will be tested only for the antigens that you inject, and the humoral immune response without memory it builds, that can be tested. And this mouse can receive the graft easily. When you transplant a graft from this mouse, you take a skin, part of skin from this mouse, and transplant into nude mice. The nude mice will accept it. It will not reject it. The reason being, it cannot mount an immune response, which I explained to you earlier. This type of immune response, effector mechanism involving Th cells and CD8 T cells and TDH response, all that is not present. It is absent. Since this immune response is absent, whatever the antigen that is this mouse is going to recognize now, is only through the B cell lineage, and it will be very, very slow. Okay, very, very slow, and the rejection will take place very, very slow through the antibodies. And there is no class switching mechanism. Whatever the antibody this mouse is going to produce will be of IgM type, and that IgM will be responsible for the rejection of the maybe after 1 month. Initially, the graft is not going to be rejected. It will be accepted, and will be rejected after 1 month only when this mouse produces the antibody against that graft, and then only it will be rejected. It will be so slow, the immune response. But generally, people are born with normal thymus. They are not thymic. But why I gave this example is formerly, for the immune reaction to be prevented against the graft, people, in fact, it was in practice. It was in practice before the immunosuppressive drugs were discovered, before the discovery of immunosuppressive drugs, which came after 1985. And before that, the people's thymus used to be compromised, either by thymectomy. The thymus used to be removed. By removing the thymus, the person used to be compromised as far as cell-mediated immune response is concerned, and therefore the graft used to be accepted. And minimum reaction used to be there, and somehow through other immunosuppressive drugs which are clinical, which are known, like steroids. Steroids are very well known to suppress the immune response. The graft used to survive in the patient for some time, and then the graft rejection used to take place after a year or something like that, and the person used to lose the graft. This used to be the story earlier, but now majority of the tissue grafts are successful because lot of developments have taken place. Lot of monoclonal antibody therapies have come, and those monoclonal antibody therapies are used for making the graft to be accepted. I will stop here.